Okay, let me just very quickly introduce everyone on the panel again, just because, we have these two separate rooms, so I'll just go right down the line, starting from my far left. That's Dr. David Cribbs, Dr. Matt Blurton-Jones, Dr. Brian Betcher, Dr. Andrea Tenner, Dr. Amy Pierce, who's our medical director in our clinic, Dr. Claudia Kawas, who's the clinical core director of the center, and Dr. Charlie Glade. So let's have a round of applause for our distinguished speakers. So the way that we have done this over this past several years is that we like to open up the room to any questions. We ask that you try to keep your questions as brief as possible and not make it so personal, so that as many people can benefit from this forum as possible. And don't be shy about asking your questions. There are a lot of people here running around with microphones, and so why don't we kick it off?
Thank you for a very informative day. Regarding the clinical trials and the number of clinical trials that have already failed, are there any clinical trials currently in the pipeline that seems hopeful?
Claudia, you want to take that?
Take it away.
Amy?
I think that we always have a lot of hope for clinical trials. In particular, I think much of the hope tends to do with moving trials to earlier population and also focusing our trials and utilizing patients who have positive biomarkers at the start. All of the other clinical trials didn't use that very specific type of population.
Okay, so
I got a comment. This is like your favorite, since it doesn't matter, since I'm not a real doc. But the ones that appeal to me are the test of the Genentech antibody and the Diane study, because you actually get to treat people early for the first time. So I think that's worth mentioning. And the ones I really like are the gamma secretase modulators, at least the second generation ones. And I don't know how many of those are in phase 3 or going to phase 3. I'm not sure, but I think those are a very good chance, because they have a better safety profile than gamma secretase inhibitors, and they got a different mechanism of action. So 2 ways to win on that.
It's important that we are hopeful, but just to be realistic, at the International Alzheimer's Parkinson's meeting in Florence in March of 2013, Ezio Giacobini announced that there were 103 clinical trial failures for Alzheimer's disease. So I think it really underscores the point that we still need a lot of basic research in this area. So let's go over here.
We've heard today a lot about amyloid beta detection, progression, and that whole line of thinking. What about memantine and the mechanism that memantine works on, and particularly nitromemantine? Is there anything to be said about nitromemantine in particular as yet?
Okay. Claudia, you want to take that?
Well, for starters, I'm not sure I know what nitromemantine is. I do know what memantine is.
That's down at the Salk Clinic. The Salk Clinic has determined some mouse model evidence on nitromemantine, which is a molecule added to the receptor that the original memantine is working on. So it's an augmented memantine.
I see. Okay, well, I personally can only comment on memantine, and I guess I do sort of know a little bit about that. I was actually the chair of the FDA advisory committee that recommended to the FDA to approve it. Even the mechanism of memantine is a little controversial, and a lot of basic scientists felt that memantine was more likely to make patients worse rather than better. But the clinical trials showed a small but consistent effect that primarily is in moderate or severe patients, interestingly enough, the opposite of all of the amyloid drugs, where if anything it looks like it's more likely they're working in the beginning. And that might give us some clues, I think, to the fact that the disease process is probably quite different at different stages. And personally, I think Frank and a lot of other people think that I have single-handedly wished doom and gloom on every trial to fail. And that's not the case. I want a cure more than anybody else in this room, probably. But I do think that the one good thing about these 103 failed trials is that it's made people take another look at other mechanisms and other strategies for trying to deal with the disease. And I think that's a really important thing ultimately for us in terms of getting success. So I talked a lot and I didn't really answer your question, did I?
Okay, we have a question here on the left.
We've heard that the Mediterranean diet is a good idea. Are there any other studies, the 90 plus, that have shown like vegan or anti-inflammatory diets have any benefit for the brain?
Andrew, you want to take that?
Well, actually, I think Claudia would
Okay.
do much better.
Okay, you can't pass the buck all the time here. Okay, Claude.
I like the Mediterranean diet just because it tastes good.
Go for it. I honestly know nothing. I mean, really, they keep putting it on me because I'm the one who finds it easiest to say I haven't a clue. So I know of no real data that convincingly tells me that a vegan diet or almost any other kind of diet is specifically good for the processes relevant to Alzheimer's disease. I do, however, believe, and I think most of the data that you see tells us that a good diet is important for good health, period. Heart health, brain health, and I think in the end it does reduce our risk of cognitive loss. I think the term Mediterranean diet has just sort of become a term people kind of like to use as shorthand for just saying a diet that has a lot of good stuff in it, especially plant-based good stuff, and a modest amount or a limited amount of the not-so-good stuff that, you know, as I told you in my talk, your mother told you, you know, that the French fries weren't as good for your diet as the spinach. And so I think it's just a shorthand for saying diet matters. But my personal feeling is just like there's not one vitamin E or vitamin X or vitamin Q, I don't think there's one food. You know, this whole notion of superfoods or eat blueberries every day and your whole risk will go away, that's just unfortunately not going to be that simple.
So, David, I know you're a scholar on red wine. Do you want to maybe offer any opinions there?
That's the second time today I've heard that comment, and by two different people. So there's resveratrol that's been found in red wine, and there's some evidence, I guess, and so at one time the concept was red wine was better than white wine, and non-wine alcoholic beverages were bad. I'm really the wrong person to answer this question. I think that passing the buck again to Claudia, because people that actually study this in the human population, I mean, we talk about exercise, and Carl Kottman and other people have done animals that run, and the animals age better. They're cognitively better. They have increased BDNF receptor, increased BDNF, reduced amyloid. But once again, I told people in our session, that was the research section, that we've had 103 clinical failures in humans, and we've had more than 103 clinical successes in transgenic animal models. So I'm not I'm not a clinician, so I can say this. Maybe one glass of red wine a day, but I think you also probably some good exercise and some good conversation, and being physically and mentally active is, one of the things is we're living a long time. Somebody was talking about this morning that I guess it was Claudia was talking about that 50% of the people that are being born now will probably live to be 100 years old, and things change just like your car, and 100 years for your body to work, you're asking a lot. So I think we should enjoy our time here and be thankful for what we have. And well, I'm going to go out on a limb here and say moderation, and I want that on the record. So.
And for what it's worth, we fed some of our mice resveratrol, and we found that it had no effect in terms of improving either the pathology or the cognitive abilities of the mice. Okay.
It's been really helpful for me.
For what it's worth, resveratrol, which is the ingredient that everyone likes in red wine, was also fed to humans, where it also appeared to have no benefit. So.
I'm asking this question because I notice there's a lot of people here in my age bracket. I just turned 75 last month. And my question is, Several presenters are happy that younger people are coming into the clinical studies. My question is, as we age, we rapidly start having more and more symptoms, and the disease may come on us faster. Do you know if there's any specific particular age that it's too late to prevent or slow down, or if there's any age that we reach that we might not have much more hope?
Okay, Claudia, you're the expert on the oldest old, so we'll give you that one.
Absolutely not.
Okay, let's go to the right-hand side here.
So I'd like to add to that, and I think that when we're talking about novel therapeutics here, and we've talked a little bit about things that could be, and many of the that already failed tests were done on certain kinds of targeting amyloid, and that's what really appears to have to be done earlier. On the other hand, some of the more novel things that we would like to do, like suppressing inflammation, we may very well be able to slow the progression of the disease, not eliminate it, but slow it at times in which we actually are beginning to see some deficits, because you're actually slowing the actual death of the neurons and the synapses, or allowing remodeling of the synapses to occur. So I think that there's hope for the future, and that's what many people are looking for. That's why we're looking for something novel, something different than what has been going on. And hooray if we can get rid of the amyloid, but there's always going to be somebody breaking through or getting to a different stage of the disease, and that's where we need to have these other kinds of therapies in line, and that's why we still are looking at those. So I don't think that there, again with Claudia, that there isn't any, it's too late, except if individuals might be totally gone and there's nothing left to reconnect in the brain. And I don't know what that stage is, but that would be the only time I think it would be too late for any hope for the future. But it's not today.
Yeah, except for that's where stem cells may come in to regenerate the brain. So, Matt, you want to comment on that?
I'd like to make a comment about Frank mentioned 103 failed clinical trials, and somebody in one of the sessions was talking, and that was in 2012, and now it's 110. But I think that the clinical trial design, and that was mentioned earlier today, is going to get better and better, and I think the biomarkers are going to help us pick a better population, and they're going to also give us a readout of whether the therapy is working. And I would like to, in my own mind, I think of those 110 drugs that have been tried in the clinical trials, I think a lot of them had little or no hope. There was no strong rationale for, ginkgo biloba and some of these, there was. So I think that things are going to get better, and I think that there's going to, when there was no hope at all, people would say, oh, well, let's try it. But these things are expensive, and you're involving humans, and so I think some of it has had to do with the fact that there was just poor choices in the drugs that were used in clinical trials.
Okay, over here on the right-hand side.
Yes, thank you. I wondered, with the finding that treating hypertension in the elderly had a negative impact on the development of Alzheimer's, if there was any intent to perhaps look at transcranial Dopplers to get a better handle on the cerebral perfusion?
So that's a great comment. I mean, the first thing I want to say is it's not treating of hypertension that resulted in a bad effect. It's that individuals who had low blood pressure, but low might be along the lines of what you and I often call normal, were more likely to be demented if they're in their 90s. I don't know that the treatment got them to that low level as much as I suspect it might even be that the dementia leads to the blood pressure decline or other processes relevant to the lifetime experience are leading to declines in blood pressure before these individuals become deceased. Now, having said that, your question was?
I was just wondering to monitor the cerebral perfusion, perhaps within middle cerebral artery, Doppler studies.
Yeah, we're really interested in this, and we haven't yet added cerebral perfusion measures to the protocol, but I think that that's going to be one of the next steps. The other thing that we are about to add, though, in the next month or so, is I think that we make a mistake when we draw conclusions from one blood pressure done one time in the clinic. And your blood pressure varies a lot during the day, and it changes when you stand up, and it changes when you're asleep, and it changes when you're dreaming compared to a different stage of sleep. And all of these measures are probably relevant for the risk. It might be, for example, that there's nothing wrong with having a blood pressure of 110/60, except that when you go to sleep, you might drop to 70/40 because you started a little lower than other people, and so that actually is the risk. So we're really trying to pinpoint the real mechanism of this risk and how it happens. And cerebral perfusion is our major interest. So I think you're on the right track. We need to figure out why these people might be getting less, if it's even true that they're getting less perfusion than individuals with higher blood pressure.
Okay, let's go to another question here.
Okay,
Gary.
there's a short answer to this one. I'm wondering if the amount of anesthesia that a patient goes through, is that part of your profiling? When you get your sample bunch, and then the other people that are actually going through your study, is that taken into consideration? Because I've been an RN a long time, and there's this thing about, your brain cells die.
Amy?
Certainly that's well noticed anecdotally among nurses, physicians, and certainly among patients and their family members, that people have a decline in cognition after anesthesia, which may improve but may remain. And in our research algorithm, when we're monitoring participants, we don't directly calculate or measure how much anesthesia they get or anesthesia exposures, but I think it is something that a lot of people are concerned about.
David?
I know there's not a lot of interest in mouse models, but there is data out there in transgenic models where anesthesia increases tau phosphorylation. So take that with a grain of salt, but there's a number of groups that have shown that. So.
Okay, let's go to a question in the back here.
Did you want to make a comment?
I was just going to add quickly to your question. There's a really large literature that's growing right now on post-operative cognitive decline, which is directly related to what you were talking about. And that's the idea that after an operation that you do have this cognitive decline in elderly people. And the animal models suggest that it's could be strongly related to inflammation, that just the procedure itself, even apart from the anesthesia, releases this inflammatory cascade that we think can exacerbate cognitive decline. But it's still kind of a hot area of research, and we have so many anecdotal reports of our patients coming in and reporting this decline, and we just don't know yet what puts you at risk and whether or not you have underlying AD pathology, and that's but are just not clinically manifesting it, and then you have a surgical procedure, and then it unfolds. It's still being researched right now, but there is a good body of literature that's coming out on it.
Okay, let's go to the back here.
You had mentioned low blood pressure. When you rattled off those numbers of 60/110, that's not far from athletic blood pressure. So if I've been athletic all my life and that's my blood pressure, are you looking at that I may be getting brain damage for being athletic?
You don't look like you're over 90.
Oh, so it doesn't matter if I'm young then.
Right.
Just don't make it to 90.
Age matters, right.
Okay.
Everything that I showed you is in individuals with a mean age of like 97. And I guess one of the points I really, really want to bring home again is that what is a risk factor in your 30s, 40s, and 50s is, for example, ApoE is a very strong risk factor. You've heard that. Everybody knows that. If you're an E4, you have at least twice the lifetime risk of developing Alzheimer's disease. In 90-year-olds, ApoE4 is not a risk factor for the development of dementia. And we have several people in the study who had 2 4 alleles and are still not demented in their 90s. So I think whenever you're considering risk factors, I guess what I'm trying to say is age really matters. If your blood pressure is low now, and if it stays low, no, I do not think that you are at increased risk, unless you're 90.
Okay, over here.
Thank you so much, you guys. You did such an outstanding job. And we did discuss some pharmacology, and I was wondering if off the cuff you could tell me if there are any drugs that are specifically contraindicated for Alzheimer's patients when it comes to psychosis.
Amy, Claudia, you want to take that?
Yeah, my two clinicians.
Bring it on.
So all of the antipsychotics, both the typical and atypical, do have a black box warning by the FDA, which means that they have been associated with elevated risk of mortality in elderly patients with Alzheimer's disease when they're being used. And those are probably those are ones to watch out for. But that being said, on occasion we do still use them. If in particular a patient has violent agitation or psychosis, as if they're a risk to themselves or to their caregivers or others, then on occasion we do use them, but we try to use them for a short period of time at the lowest dose necessary. Agitation, psychosis is extremely difficult to treat in Alzheimer's disease, and all of the medications, when used in clinical trials, don't show dramatic benefits in terms of improving these behaviors. Usually, behavioral modification, which means caregiver training, changing the environment, works better than medications. But it's a big field of inquiry, and actually clinical trials, including one right now, is trying to study new agents looking at the agitation and aggression in Alzheimer's disease in later stages of disease. So a lot of our trials are aiming towards early and mild patients, but certainly we still need to pursue new and novel treatments for more advanced stages as well.
Okay, let's go
Actually,
to
Dr. Pierce should have also told you that she's about to start a clinical trial looking at agitation in Alzheimer patients with a novel compound. So anyone who's exhausted other avenues of success and wants to try a novel treatment.
Okay, let's go to the right-hand side.
I just wondered, is there currently a way to reduce inflammation in the brain for current patients?
Andrea?
Not that has been really studied and tested really well. It's really difficult to demonstrate a decrease in neuroinflammation now in live patients. You can really look at inflammation in deceased individuals, and you can do that in animal studies. But in an Alzheimer's disease individual, we're just beginning to have, and I'm going to pass this over to her in a minute, because we need to be able to see things like microglia and microglia markers, and they're trying to develop those kinds of imaging markers now. And I'm going to pass that to her so she can.
Yeah, I was just going to ask whether any studies had been done with paraspinal etanercept as a method of reducing brain inflammation.
Well, again, there isn't a measure of brain inflammation that one can follow, like you can follow now amyloid plaque deposition. So there isn't a measure for that. The different numbers of people have postulated using those anti-TNF alpha reagents and drugs and therapies, but that has not been done in a major clinical trial that I know of. I'm pretty sure that's it, right?
Okay, let's.
We don't even know if etanercept even gets into the brain. As you probably know, the guy who's promoting it injects it into the paraspinal region and kind of makes a story that maybe somehow it can get picked up by lymphatics and maybe get into the brain, but we don't even know that it gets into the brain. The other thing is that I think that looked awfully promising a few years ago, and the fact that you've not seen anything since then is unfortunately very telling. I think that the initial promise really has not held up, unfortunately.
Okay, let's go over here.
Thank you all again for your time and expertise today. I know we've all found it to be invaluable. Piggybacking on the first question of the Q&A, I'm curious if anyone on the panel has a comment about the phase 3 clinical trial of LMTX, looking at the impact on the tau. Would any of you have a comment on that?
Amy, any comment? No?
Probably. Can you remind us which company or a little more about the drug, because we're all not even sure which one you're mentioning of the next 103? Oh, so it's a tau aggregator. Yeah. Yeah. Okay.
Was that the methylene blue? No?
90% reduction in the progression of the disease in the phase 2 trials.
Measured how?
I'm sorry?
How did they measure that there was a 90% reduction in
Compared
progression?
to those who got the placebo?
So phase 2 trials, I mentioned in the research session that we just ended, and Claudia can talk about this a little bit more. She's been involved in the design of clinical trials, and so one of the things is typically phase 1 and phase 2 are not powered to see an effect. So if they saw an effect, it might be impressive. In my presentation, I commented on the fact that a number of drugs in clinical trials have looked promising, IVIG in the phase 2. And so I'm not trying to discourage anyone, but ultimately we need to wait for the phase 3 to really see whether this is working. So
Yeah, they're starting the phase 3 trial now. So,
okay.
we'll
So
see.
in a couple of years, we'll know.
Gary?
Sooner than that, because if it's 90% drug effect, you can find that out pretty quickly. So, and I'm sorry I'm not familiar with that particular data, but I will say this: I really think that making neurofibrillary tangles a potential target is a crucially important and potentially useful thing. So,
okay, in the back.
Hi. I was wondering if there's any correlation between patients who develop delirium when they're ill and later developing dementia. And the reason I asked that, I noticed in my own father that probably a decade before he ever became symptomatic, when he would have a fever or be in pain, he would start hallucinating and
Ramona Hopkins in Utah did a study that I actually reviewed for a journal, and she found it very highly mentioned.
Brianne, you want to comment?
Yeah, I think there's a great literature on the link between delirium and dementia. And I think there's similar mechanisms that we were talking about with surgical procedures. And so a lot of the science revolves around these inflammatory processes. We still don't know enough to know exactly if you have a delirium, how much that changes your trajectory. But we know that if you even have something like mild cognitive impairment and you go into a hospital, you're more likely to develop a delirium. If you have a delirium, it's more likely to exacerbate your cognitive course. There's been a few articles in the last year that have tracked that, and so it's something that I think is very tightly linked that we'll probably need to do more research on.
Okay, let's take one more question in the back here because we're approaching the witching hour here.
My husband has he has Alzheimer's disease, but for many years he's had both Crohn's and psoriasis. Is there any indication that the autoimmune disease at an earlier age increases the risk of Alzheimer's?
Andrew?
Yeah, it's actually almost contrary to that, and mainly not because of the inherent processes, but in terms of the treatment. For example, people that had rheumatoid arthritis and were treated on a high dose of steroids seemed to show in these prospective epidemiological studies that they had a lowered risk for Alzheimer's disease. So inflammation, though, in the periphery, in the body, does seem to be correlated with a faster onset or greater progression in many studies. We still don't have all the answers, but it certainly looks very interesting. So ongoing inflammation does seem to have an effect. But if it's being treated, then you're reducing that inflammation, then that's almost protective because you're reducing inflammation on all the other things. So it's one of these very complex situations that's hard to predict then from one course to the next. But I mean, inflammation in the periphery, with the induction of things like TNF-alpha, is not so good. But that doesn't say that that's the only thing, or that's going to be the driving force in any one particular's demise.
So we're at that time where we should really come to a close here. Let's thank the panelists for their expertise and for the Ask the Doc forum. And I know a few of you probably still have some lingering questions, and I'm sure the panelists won't mind answering them one-on-one. In the meantime, on behalf of the Alzheimer's Association and Jim McAleer, and also on behalf of UCI Mind, we really appreciate all your support and coming out for a really, I think, truly spectacular day, and hope to see you back here next year. Thank you all.
Very clever.